very much for being here. My name is Renato Ambrosio from Rio de Janeiro, Brazil. And I'm going to talk to you about AI detection for optimizing diagnostics in the world of refractive surgery, and we're using ultra-high resolution OCT images as well. I work with many companies, including, of course, Oculus, and I have the privilege to work with Oculus for more than 20 years now. And I remember when we celebrated 10 years of Pentacam. It was at the AAO in Chicago. So time is flying, but evolution is even going faster. And this evolution is the Pentacam family. The Pentacam family that when we celebrated 20 years, now a couple of years ago at the Academy, we talked about the line of instruments that use Scheinfeld rotating technologies. So we have the Pentacam standard Scheinfeld camera, the Pentacam HR, we have the AXL, we have the XL Wave, and now we have the XL, the Pentacam high resolution with a high resolution OCT as well. So for many years, I had to behave not to talk about the new kid that we would have soon. So I'm honored to collaborate with Andreas Scheimiller for many years. And when he showed me the first pictures of the high resolution of the spectral domain OCT, I was almost blown away. That's like the tissue, like a biopsy. And that's what we word. Words matter. We talk optical biopsy. But when I tell my patients I'm going to do optical biopsy, they are afraid. They think I'm going to cut their eye. So I have to say is a non-contact optical biopsy. It's just pictures of your eye. We have a very special way of doing these pictures with OCT technology, and the OCT technology can give you this optical biopsy with unprecedented detail on the level of the tissue. So we have it integrated with Scheinfeld. Synergism. Synergism is when 1 + 1 equals more than 2. Of course, you can have antagonism. Sometimes 1 plus another 1 equals 0 or less. But here, Scheinfeld technology that gives you blue light in the visible spectrum is additive to the OCT. So a lot of people in the floor are telling, Scheinfeld is gone. Think about OCT. And I think, think about going beyond, but not over. That's even my philosophy of life. So the additive of spectral domain OCT will give us more information how to help the patients in making better decisions. So we have this ultra high resolution image, and we have less than 2 microns. And I think we are a little bit conservative here with 1.9. But the point is we have a lot of data that we never had before. So what is the OCT, the corneal OCT? First is a corneal OCT. The name is important. It's not an anterior segment OCT. So you won't be able to see the angle with the OCT. You'll be able to see the angle with the Scheinfeld. So all the benefits you have from the Pentacam Scheinfeld rotating camera are retained. So if you have a Pentacam for many years, all your patient's data will be transferred to the computer that you have the new Pentacam, and you'll be able to go back and see this data. But be careful. When you guys that want to sell the Pentacam OCT, don't tell your doctor that they will have Pentacam OCT data from 20 years old measurements, because that will be not possible. But they will be able to see the Pentacam data that they had and eventually get a new Pentacam and still be able to do the comparative exams and all this follow-up is there. So it's a spectral domain OCT with a broad bandwidth with high 200 nanometers that goes across the cornea is in a perpendicular way. So when you go across a cornea in a perpendicular way, you can have a very nice high resolution from a big area that goes up to 16 millimeters. And in 1 second, the rotating Scheinfeld and rotating OCT will take these images together. So you have a very nice covered, and this makes the cornea very nicely, properly measured. So what we have today is a true spectral domain OCT non-contact corneal biopsy. I have to say non-contact because people are afraid of being cut for biopsy because they know what biopsy is. So I like a little bit philosophy. So if you don't know what you're looking for, you don't know what you're finding. But if you know what you're looking for, you need to have the proper tools to evaluate it. So if I have a patient that has a scar, I know what I'm looking for. I want to see how dense is the scar, how deep is the scar on the cornea, if I can do a PTK, for example. How is the irregularity generated by that scar impacting the patient's vision? So you need to have the proper questions and the proper answers on the ways of measuring. So I like when Andreas Scheimiller gets the metaphor of putting light. He is just turning light. So I remember when I first was using the Pentacam Scheinflug with the older camera, I went to my clinical practice very happy because I was very happy to see these beautiful images of the lens, of the cornea, of the angle. But you get more and more, let's say, demanding with the quality of the images. So we have the high resolution, now ultra high resolution. I think you have to frame that the Scheinflug camera got better itself. And we have this unprecedented detail. So from the Scheinflug image to the spectral domain OCT image, we have a lot of detail. And it can help monitoring a patient with infective keratitis. You see how the infective keratitis infiltrate is shrinking or getting worse. You can see things that we don't know eventually what we are looking at. And eventually this will translate into better medical care for the patients. So it's like turning out light. And this innovation makes us a challenge because the amount of data is amazingly high. Even the amount of gigabytes. You know, a Pentacam has 24 megabytes for storage. One OCT Pentacam, it's 800. It's even hard to transfer this data for analysis. With fast internet, everything gets better, and with the computer technology gets better. But we have one thing that cannot expand. We cannot expand the speed of internet. So transferring the data, instead of 10 seconds, it goes to 1 second. Okay, great. But we don't have more time to expand. We cannot expand time. At least we can partially. If Einstein was here, he may probably get some controversy on this idea. But the problem is that time is limited for us. So we need to be effective and efficient. So we need to use time. And that's why AI is a solution. And here we have Shiva that is doing a great job with Sven and all the R&D with Nicholas and all this great work that we are doing to make this available as a practical system for the user so that we can use this technology as to help the patient. So when you think about diagnostics, we talk about multimodal. Multimodal is going to start not with any machine, but with anamnesis. We ask questions. How are you doing? Are you feeling better? And eventually that can be also overwhelming because some patients, they want to talk about the family, how they get to the office, how they're feeling today. But we need to be objective. And eventually even that can be optimized with AI. But when we talk about imaging, we have multimodal imaging from topography to tomography, Scheinflug, OCT, wavefront, axial lens. And with this plethora of data, AI is fundamental. And I love this algorithm, A2I squared, is applied artificial intelligence with applied ancient intelligence. I can give you all the libraries from the R. It's not going to be any help if you don't know how to use it. Or if you know how to use it, you have a team of computer scientists, PhDs, but they are eager to program and you don't have the questions. It's not going to be helpful. So you need to have ancient intelligence applied as well, which is the wise, the philosophy. And interestingly, we can go even beyond. So it goes to A2I on the third level. So, oops, that's AI. It's talking, you have to be faster because almost gone through time. I don't know what happened. But so when we think about AI, the definition of AI is having the possibility of the device do human things. I will just cross human. But when I cross human here, is that AI is not doing what we can do. It's going beyond what we can do because we can integrate 4 or 5 parameters, not more than that. So AI is not to replace us, it's to empower us. That's a very important fact. And AI started in ophthalmology, started in keratoconus screening, the work by Steve Kleiss with Maeda and Smolek in the 80s for using neural networks. And this is one of the cases that his AI would say is green. 23 years old, the patient came as a refractive candidate for low correction. And I saw this patient for the first time, and thickness is within the normal range. It's 545, 550 plus or minus 30. So it's within the first standard deviation of normality. And when I first saw this patient, they sent me the Pentacam data. And I'm just going faster here so that in the sake of time, we have a TBI 49 and 50. That's the TBI V1. And the TBI V2 is 99. And this patient developed ectasia after PRK in both eyes. So the enhanced ectasia software that we developed, which is the BEAS. BEAS stands for Brazilian Artificial Intelligence Brain Enhanced Ectasia Software. Ectasia happens because of 2 facts. The intrinsic fact, which is the patient's cornea, and the extrinsic fact, which is the environment. The most important environmental thing is eye rubbing. So is AI on the ancient intelligence level telling people not to rub the eye? And is AI to quantify the impact from surgery? If you're going to do LALEX or KLEX or SMILE, whatever you want to call, or LASIK or surface ablation, you would cause an impact from the cornea. So when you screen for ectasia risk, you're not only trying to detect mild keratoconus. What you're trying to do is to understand if that cornea can be safe after the weakening that you cause with your laser vision correction procedure. And the B is operationalize this. Because we have, if you have only Pentacam data, you'll be able to use the BAD V4 I, which is a better algorithm that uses shine fluid tomography that would give you a more accurate data for enhanced ectasia detection. The BAD V3 is excellent. The V4 is better. When I say it's better, it's because of studies, and that's published on Nature. The BAD-D can be integrated with the shine fluid dynamic system, the Corvis, and then we have the TBI. And then you have the extrinsic factor, which is the relational tissue altered, that would integrate age, the parameters from laser vision correction, flap or cap, ablation or lenticle, or surface ablation. And then you integrate the relational impact that's going from 0 to 1 to the intrinsic cornea, which is the BAD-D or the TBI, whatever you have. And this is an example here. This is a patient that came as a candidate, 20/20 -1 in the right eye and 20/15 in the left eye. So you see this case is a mild keratoconus. I would say is a mild keratoconus. Yaron Rabinovitz, great friend, rest in peace. He taught us topography is important because we can detect these cases, and he would call these cases form fruit keratoconus, the right eye of this patient. This patient has a topometric and tomographic keratoconus in the right eye, but it's 20/20 -1 with a normal slit lamp. The left eye is a very asymmetric ectasia. Everything looks relatively normal, but you see the TBI is 0.58. The epithelium is thin compared to the surrounding area. So it's a thin epithelium. So we add a layer of analysis with a segmental tomography data, which is epithelial thickness. I think epithelial thickness is one of the most important analysis for refractive surgery because it helps us. It has helped refractive surgery since ever. because the epithelium would mask the irregularities, smooth out the surface. And according to my good friend and professor, and even doctor, I would say if I ever do refractive surgery, then Reinstein will be my surgeon. So according to the Reinstein law of epithelial compensation, the epithelium reacts of the protrusion. It thins over the peaks, thickens, like if you do refractive surgery for myopia, it will thicken in the center. And all this is to try to smooth out the surface. And the interesting idea is that here we have the epithelial thinning, even though the epithelium is not thin. And for that type of consideration, we need to have precision. Precision is the amount of repeatability capacity that you have for the system. So for that type of precision that you see the thinning from 51 to 58, it's not thin. The epithelial thickness is 48. So 51 is thicker than the average, but it's thinned if you see the donut shape that Dan Reinstein described. So the corneal epithelium has the ability to compensate. It acts as a smoother. It's not the first phenomena by definition, but it's a very important metric for us as refractive surgeons. So we need to have precision. And here we have Alex, who is doing his RSA fellowship, and his thesis is on the epithelium OCT capabilities. The important thing is that from measurement 1 to measurement 2, what happened? We discovered that we have something called tear film on the top of the epithelium. And the OCT capability, now I just saw that with the segmentation, with the 2 lines on the epithelium surface, that, okay, what is this? This is the tear film. So you can see that. And once we have the tear film influence removed, the repeatability, that's the maps without the epithelium. We improve the repeatability. So we're talking about Solix, MS39, and Pentacam corneal OCT. They are all excellent. But the repeatability, when we remove the epithelial thickness and the tear film, it got a level extra of quality. So we did a study looking at 40 healthy patients. This study was done in-house at OCULUS, and we did a Pentacam, corneal OCT, the Solix and MS39, 3 measurements in each device. And we use this as the parts that you are analyzing for each of the sectors, repeatability for each of the devices. So there's a lot of statistics involved. But the Pentacam OCT is equivalent to the Solix and MS39 somehow, yes. The repeatability of all of them are excellent, but when we think about the central epithelial repeatability goes from 1.47 to 0.78. So the repeatability is better. And if we're trying to see 5 microns change, that sigma, that standard deviation, that precision is absolutely fundamental. So higher precision due to this work. And this is submitted to publication soon through my colleague, Alex. So it's important that all of them are very good. So the next thing is AI helping us, because we have 24 to 30 images on the cuts that we have on the OCT, and you don't have time to go through all of this. You don't have time. But AI does that in fractions of seconds, thanks to the great work that Shiva and her team are doing. So what we do today, you detect where to look, and it flags. And then you see which cut you have to see. And after that, you are optimizing your time. So that's what we have in the displays. So it's a case presentation. So we have a 72 years old that has a little bit of a change in the refraction. And you see this here. I can flag this. But when AI comes, it's going to be very important. Case 2 is another one that would say you have this irregularity I can show it to you, but AI would just make it much easier. And you can use it for endothelial disease. A lot of people say keratoconus is important, but I would say more important than ectasia keratoconus is endothelial disease and refractive surgery, especially intraocular refractive surgery. And you see haze, you can see different scars, dystrophies, degenerations. And of course, this is not going to be finishing in the corneal tomography data. We have unmet needs for ocular surface, and then we have the ability to see meibomian glands, and also more things on the AI for helping us. So AI is here to help us. It can grade, it can objectively metric, and all of this information will help us to do AI optimized diagnostics. Is artificial intelligence with applied ancient intelligence empower efficacy and efficiency for physicians. It's different. A lot of people say, what is the difference between efficacy and efficiency? Think about it. One is the how, the other is the why. I can be very efficacious on my task if you tell me, Renato, you should review this paper, and I take this paper to review, and I take 2 months to review. I got the purpose. I fulfilled my mission. But I had to read 20 books, ask to 10 professors to review that paper. It's not efficient. You want to have a mission, and the mission is your why. And you need to know what you're trying to get and how you're going to get in the most efficacious way as possible. Clinical relevance and the standard of care is optimizing technology, knowledge, and how to apply this, to operationalize this in the best way as possible. Integration and synergies. And with that, I thank you very much for your kind attention.